Good morning. It's Wednesday, December the 28th. This is when I normally host an episode of Open Mics with Dr. Stites. But Hawkeye, Jess, and I aren't actually here today. We've recorded this introduction to one of our favorite episodes for you to enjoy while we're spending time with our families.
Okay, before we get to that, can we talk about the fifth Beatle over here?
Yeah, he's,
I like
you know what I think, is this a wannabe thing? Because and they all have little hats on too.
Very
Yeah.
cute.
He's
I
pretty
love it.
cute.
You
He's
guys,
pretty cool.
Beatles are
you
great.
guys got the
Yes,
memo
like
with your little outfits.
Yeah, let it snow, let it
love it.
snow, let it snow.
Okay, let's talk sleep.
Okay.
Okay, if you get any. Okay, so I was up at 4 a.m. this morning. Did you guys get a good night's sleep last night, though? No, never.
How much do you sleep at night?
Not enough.
Nah, same here. My
Never.
sleep hygiene, not good.
Never enough. So we have discovered during the pandemic that a lot of us have not been able to get really good quality sleep.
Absolutely. And last July, we aired a wonderful episode with one of our sleep medicine experts who had some great advice for getting a good night's sleep.
And by the way, this is one of those times where we say, do as I say, not as I do.
Thank you for saying
We
that.
also heard about some of the exciting new technologies available to help those with sleep disorders.
We hope you enjoy this Encore presentation, and we want to remind you that we'll be back next Wednesday, January 4th, with all new episodes of the Morning Medical Update and Open Mics with Dr. Stites. Until then, Happy
Happy
New Year, everybody.
And don't fall asleep on this episode.
How many hours of sleep are you getting each and every night? And is it ever really enough? Our expert shares new data and actually shows us treatment devices used to help you find a path to better sleep health. Plus advice for parents to get their kids on track ahead of the school year. And good morning, everyone. It is Monday, July 25th. I'm Jessica Lovell, and we are live here inside our Midwest facility here in Shawnee, Kansas. So glad you're joining us this morning on Facebook, Twitter, and YouTube. 100,000 new cases of COVID each and every day. So the numbers are in. The question is, are we going to have to mask up again? Dr. Dana Hawkinson and Dr. Amber Schmidtke join us with the latest. Plus, the latest advancements in sleep medicine and how to make sure you're getting enough sleep. Plus, what an at-home sleep study is really like. Sleep medicine specialist Dr. Sarah Luthra is joining us to help out. We're going to get with him here in just a few moments. But first, we're going to talk a little bit about a conference that he just came back from and get some new data that he's going to share with us. So we're looking forward to that. Thank you so much. But tell us what's on your mind today. You guys always have really great questions. You can send those in to us at the Medical News Network. You can send them to our Facebook, Twitter, and YouTube page. You can find links to those right there on your screen. But first, we know the number of COVID-19 cases is growing, so we want to get to that off the top of the show. Alexis Del Cid is joining us in our studio alongside Dr. Hawkinson, and we've also have Dr. Amber Schmidtke joining us as well. Good morning.
Also getting a lot of questions from our viewers who want to talk about and get some answers about President Biden getting COVID despite the fact that he was vaccinated and fully boosted. So we're going to get to that topic in a moment. But first, let's check in with our latest COVID numbers. We have Dr. Hawkinson back with us. Thanks for being here, and good to have you back.
Thanks. It's good to be back.
How are the numbers looking?
You know, the numbers aren't looking too good in the hospital. Again, not as bad as we saw in that Delta Omicron surge really in the last part of the last year and the early part of this year. But they are still ticking up, and we know that's because the virus has continued to circulate in pretty high numbers. So right now we have 37 active infections, with 4 in the ICU and 2 on the ventilator, still 12 in that recovery period. Unfortunately, those active infection numbers are up, and of course we would like to get back down to those single digits. So.
We do have several COVID questions coming in for you, so stick around because we're going to want your expertise on that. We also want to bring in Dr. Amber Schmidtke. Dr. Schmidtke is chair of the Division of Natural Sciences and Mathematics at the University of St. Mary. Dr. Schmidtke, thank you for being here.
Good morning. Thank you.
So my first question for you. According to the CDC, more than 93% of communities in the U.S. are in the high transmission rate category right now. So if you take a look at this map that we have, you can see we have a lot of red on that map. And researchers say we could soon have a tough time finding hospital beds across America. Well, that's not what anyone wants to hear. The CDC is urging 42% of counties in the country to mask up again. So, Dr. Schmidtke, do you think masks are going to become the norm again? And what do you make of those latest numbers in that map? Does that alarm you?
Yeah, it's always alarming when you see a sea of red, right? So what that red map is looking at is the risk that you are going to be exposed to COVID-19 in your community. The other map, which looks at access to hospitals and how much difficulty you might experience accessing a hospital bed if you needed it, is saying that, like you said, 42% of U.S. counties are in what's considered the high-risk zone for that. And so when that happens, it's really a good idea to maybe start wearing masks in your community. And I should point out that almost the entire Kansas City metro is in that high category. I think the exceptions are Platte and Clay County. And so I don't know that we're going to see the political will to reinstate something like a mask requirement. But I think that each one of us can take big and small actions to look out for people in our community by wearing a mask, making sure that you're vaccinated and up to date on your boosters.
Dr. Schmidtke, in spite of everything that you post in your newsletter, you've shared with us that you keep getting news alert headlines from national news media. We all get these headlines on our phones, and these national headlines are stating that the pandemic is not a big deal anymore. And you even got a news alert. Is this true? It read, quote, "Officials are not sounding the alarm on COVID." So how, first of all, how recently did you get that? Second of all, how concerning is that to you?
So that alert came last week. It was from the New York Times. And I kind of laughed, honestly, when it came up on my phone, because I was sort of like, well, I guess they're not talking to very many of my peers. And so it's a little bit frustrating to still be at this place and still be fighting COVID the way that we are, but to also not really have a cohesive voice about the risks that we all face and what steps we might want to consider in order to protect ourselves. I think that it certainly makes things confusing when you hear from one side of our government and our media that's saying this isn't a big deal, go back to work, yada, yada, yada. And then we hear the stories from people like Dr. Hawk on the ground saying, things are getting a little bit worse and we need to maybe take some more precautions.
It feels like every morning we hear Dr. Hawkinson sounding the alarm with the latest numbers, and we have Dr. Stites on also reinforcing that. One other question I want to ask you involving some new numbers that just came out from the Mid-American Regional Council, and we're going to pop up a graph for everyone in our audience to see. These show a drastic increase in COVID cases. When you take a look at this, you can see a significant spike in the number of cases in just the past 2 weeks. And this is here in the metro. Can you tell us about this?
Well, sometimes it's hard to really see the size of the problem when it comes to testing and cases. We did have the 4th of July holiday that kind of interrupted accessibility to testing and delayed reporting of those results. So there could be some impact there. We also don't have the most robust testing and reporting as we used to do, because so many people have shifted to those at-home tests, which are wonderfully convenient, but those results never get reported to the state or the federal government. So we don't really truly have a good sense or grasp of how much disease is out there. So when we look at that map that showed all of that red, which is the risk that you would be exposed to COVID-19, I think it's important for us to remember that that is a very rosy assessment, and even that shows an all red map. The reason it's a rosy assessment is because we don't truly see how many cases are out there. This is likely a vast undercount.
Something else that you've often said that super interesting to hear is that what happens here in the Kansas City metro is often mimicking what has just happened in Georgia. So my first question about that is, why Georgia? And then can we expect then whatever's happening in Georgia now to be happening to us here in the metro in a few weeks or a couple of months?
Well, so one thing, the reason I focus so much on Georgia is because I'm from there. But, I think that something that we should pay attention to is that infectious diseases don't pay attention to borders. And that's why, it's so important to deal with problems when they're small and in a local space, because, it's not like the virus transmits differently in Georgia as compared to Kansas. And so I think that sometimes we see sort of that canary in the coal mine. When new variants come, they tend to come to areas that are very populated, so places like New York or Atlanta that have a lot of travel. And sometimes that's where we first see it, but eventually it hits us all, right? And so I think that sometimes that can be very predictive. What we're seeing in Georgia right now is that the entire western half of the state is in that high risk category for having difficulty accessing a hospital bed. That's where things are right now. They also have a lower vaccination rate than the state of Kansas. But as you pointed out, President Biden even is getting sick, even being fully up to date on vaccines. I think it's important to remember that those vaccines are helping him to have a less severe case of COVID. And so it's very important to still have that. But I think that we need to go back to the remembrance that we don't have a single strategy with COVID-19 that is absolutely foolproof. So we really need to be layering those strategies together. So things like wearing a mask, being fully up to date on your vaccine series, avoiding crowds, bringing in fresh air, all of those things can work together to really help us.
Question for you about monkeypox. This is news that broke over the weekend. The World Health Organization declared that monkeypox is a public health emergency of international concern. We're going to get with Dr. Hawk on this in just a few minutes for Dr. Hawkinson's expertise. But Dr. Schmidtke, I want to ask you about these numbers. The CDC shows that we have 7 cases of monkeypox in Kansas and in Missouri, more than 2,900 across the U.S. What can we expect in your expertise looking at these numbers to see here in the metro?
Well, I look forward to hearing what Dr. Hawkinson has to say about this too. I think that one thing that, as a person that looks at the numbers, one thing that really kind of puts me at a place of unease about monkeypox is how explosively the case numbers have grown in the United States as compared to the rest of the world. And so that is something that it feels almost like March 2020 again. Why are we seeing cases explode the way that they are? Now, part of that is going to be because people are looking for it. And when you go looking for it, you're going to find it. And I think that, that's a good thing. We want to be on the lookout for these things. But we also need to be working aggressively to contain the spread of this illness by doing really good contact tracing and isolation, vaccinating those who've been exposed, that sort of thing. And so right now, I'm a little concerned that it seems like the national response is a little bit flat-footed. I would love to see some blunting of that skyrocketing case count, but hopefully we will not see those numbers in the state of Kansas. But like I said before, these diseases don't understand geographic borders. So we should be as prepared as we can for those cases to potentially go up here in Kansas City.
Dr. Schmidtke, thank you so much for joining us. Thanks for your time this morning.
Welcome.
I want to go over to you, Dr. Hawkinson, now about monkeypox. I know all weekend long my friends were texting me, wanting me to ask you about this. Monkeypox, should we be worried? What does Dr. Hawkinson say? So what's your take on this for here in the metro?
Yeah, so I think, again, we've known and we've seen some cases in Kansas and Missouri, just like early on in COVID, if we knew that there was a case, we believe there were other cases. I think we have to believe there probably are other cases. The best data, best information that we have to support that now is it continues to run in these certain social groups and social circles for sure. Certainly behavior is risky, but we've also now seen 2 children that have been diagnosed in the media. They've had that story. So it is very important. And I think, but there is an easy way to stop it. Just as Dr. Schmidtke said, about the flat-footedness. I think we need to roll out more vaccination, the ability for anybody to go get vaccinated against smallpox, which does have protection. The vaccine does provide protection against monkeypox. That is my opinion. I also understand there are logistics, there are supply issues with that vaccine, but we need to open up and let people go get vaccinated, especially if they tend to be in that high-risk group right now. But we know it can spread to anyone.
When it comes to the vaccine, what's the status of vaccines in our community? Who can get them?
Yeah, so right now I believe Health and Human Services are the main people who are distributing the current smallpox vaccines. Again, we have over 100 million doses of one of the vaccines, but that certainly carries with it some side effects. We have quite a few, quite less amount of vaccines for the Jynneos, which is just the injection that we're all used to with the vaccine. So I think some of it, again, maybe the supply and ability to get that vaccine, but I think moving forward now as World Health Organization just declared that, we know it is a significant problem in the United States, trying to get and ramp up those vaccine stores and supplies and get them out to the community so that anybody can really go get vaccinated against it.
Switching gears to President Biden contracting COVID. He was fully vaccinated, fully boosted. What do you know about his treatment and how that is going?
Yeah, again, he was fully boosted. That's important. That doesn't really protect you against infection. It does have some minimal effect, especially within those first few months after that last dose of vaccine. But the fact that he was infected should not be surprising. He also was on Paxlovid, so the oral therapy as well. That's about all I know as far as his treatment. I don't know if he received any monoclonal antibodies. Again, if you're receiving Paxlovid, we really wouldn't be giving the monoclonal antibodies. The initial reports that I saw was that he was taking Paxlovid according to the guidance in the emergency use authorization. So he should be doing very well. Again, he's going to be monitored probably better than anybody in the United States or in the world. So as far as I understand, he's doing better.
There is something that happens emotionally when you're fully vaccinated and boosted and you still get COVID. You're like, what? I thought this wasn't supposed to happen. But our scientists and doctors, and you've made clear, yes, you can still get it. Your symptoms just won't be nearly as bad. So can you clear that up again for people who are wondering how that's possible?
Yeah, so I think that is important to reiterate. Again, the vaccines being up to date, that means getting that booster or getting that second booster if you fall into that category, and that is those people who are over 50. We know that is like a seatbelt. So it doesn't protect you from getting into a car wreck or car crash, but what it does is help reduce that severity. And there's a new published MMWR, Morbidity Mortality Weekly Report out of CDC, which actually showed, and looking at people who got 2 versus 3 total doses of vaccine versus 4 total doses, and what they did show that if you were over 50 and you did get your 4th vaccine, it did offer that further benefit against hospitalization and severe disease. So.
Another big headline, Dr. Fauci is expected to retire by the end of President Biden's term. So in your hot take, what impact do you expect this will have on how we're handling the pandemic as a nation? I
think it'll have minimal impact. I know he's still probably going to be quite involved behind the scenes, if anything. We know they have good people in there now. Dr. Anish Jha, with the administration, is doing a very good job. I think overall he will still have influence. He will probably be back there behind the scenes, but I think it'll be a minimal impact as far as what is reported to the public and things that go on, and basically any other sound bites. So.
Dr. Hawkinson, my phone is lighting up with questions from our viewers. We're going to get to these in a minute, but now we want to check back in with Jessica Lovell. Jessica's talking about sleep today. Boy, we all could use more of that. Also, the coolest advancements to help people who have sleep disorders, and how as parents we can help get our kids back into the swing of things sleep-wise with the start of a new school year just around the corner.
Right. Alexis, it seems like, well, first of all, sleep or lack thereof is something we can all relate to. But certainly parents, I know you've got a teenager at home. I've got young ones. And it's like, is it ever too soon to start preparing them to get good sleep habits as we start the next school year? So we're going to talk to the expert about that here in just a moment. So as you're kind of preparing your checklist for school, back to school, make sure you're getting sleep on that list. I want to tell you about a study. A new study out of the Journal of Pediatrics found that children need at least 10 hours of sleep each night to get off to a good start in kindergarten. Now, researchers tracked sleep over 4 week-long periods and had their teachers then evaluate their transition to school. The teachers did not know which kids had the amount of sleep they had. The study found that children who got 10-plus hours of sleep a night, the better they performed and got along with their peers. The American Academy of Sleep Medicine already suggests that kindergarten-age kids get about 10 to 13 hours of sleep, but that, of course, also can include those naps that those young kiddos need throughout the day. So I want to bring in our sleep medicine specialist, Dr. Luthra. Good morning to you. How are you?
Good morning. How are you?
Oh, good. We always get lots of questions when it comes to sleep, and we're going to talk about kids and back to school here in just a moment. But for me, I want to know, you just returned from the National Sleep Convention. Jump in and tell us what you learned. What did you bring back for us? What's the latest data?
So I think, it's very exciting right now in the field of sleep medicine. What we are noticing is a use of a lot of newer technologies in trying to increase the access of sleep care to the patient population. Because one thing we all realize is we do have good treatments of sleep disorders, but in order to get patients to get those disorders, you have to diagnose them. So I saw a lot of technological advances that are happening in the field of sleep diagnostics, how we diagnose somebody to have a sleep disorder, and that includes devices that can diagnose them at home. So the home sleep testing devices, they are getting smaller, they are getting easier to access. There is a trend towards multi-night testing, where the patient can wear the same device many nights, because sometimes a single night does not give you a good snapshot of your sleep in general. So a lot of multi-night testing devices, and then there are advances on what else can be done other than CPAP for management of apnea. So devices like nerve stimulators, they are getting smaller, they are getting better in terms of managing sleep apnea.
All right, we're going to talk about both of those devices, but first we're going to talk about that at-home sleep study, because is that kind of the standard now? I have to tell you, Dr. Luthra, probably 20 years ago, I did a story where I went to a big sleep clinic, and I had every wire you can imagine hooked up to my body, and they put me in this simulated bedroom, didn't quite feel like maybe I was getting the best assessment of my sleep, because I'm not at home and I'm not sleeping the way that I normally would. So tell us a little bit about what we're looking at and how these are helping you get a better read on people and their sleep health.
Right. So you're exactly right, Jessica. So we still do a lot of polysomnograms which are done in the lab. But it does take you outside the home, so you don't get that natural pattern of sleep.
Okay.
And also, it is easier and more feasible to do the home sleep test on a bigger patient population. So these are the two devices.
Okay.
The one you have in your hands is called WatchPat, and this is working on a technology where you just put it on your wrist like a watch, and it has this pulse oximeter type device that goes on a finger. And a lot of patients with COVID now know how to use a pulse ox device. So this goes on your finger, that goes on your wrist.
Okay, so you sleep with this on.
You just put that wrist on, and there is a sticker here, and this just goes on in the middle of the chest and sticks on there, and that's it. There is no device there then on the nose, nothing obstructing your face, and you just read the instructions, and the instructions are also given by the lab, and sleep with it for one night. You make sure you get at least 6 hours of sleep, and next day you return the device and we get a report from this.
And what's it going to tell me? What's the big thing you're really looking for?
So the big thing we are looking for with this device is how many times your breathing is getting obstructed at night, and how is your oxygen responding to that. So basically diagnosing sleep apnea with that device. This is a more traditional format of HST which we still use, and has a more standard way of diagnosing with, again, a wrist device and a finger device. But this also has a chest strap, and it has a cannula that goes under the nose, and it's a thin cannula, almost like when you get on oxygen you have a thin cannula under the nose. So this works on a more standard way of looking actually at the airflow in and outside the lungs to diagnose sleep apnea, whereas this interprets your heart rate signals and then analyze them to understand how much apnea you're getting.
So how accurate are these?
Both are very accurate. I think both of these studies, when they were compared to the polysomnograms, they were more than 90% comparable to the results we get from a polysomnogram as far as the apnea is concerned. Now, we would still use polysomnograms in the lab sometimes, which is when patients are starting on treatment or they're on treatment and not doing well. We want to titrate their devices, get a more precision settings on them. Or if somebody has a sleep disorder which we think is other than breathing disorder, for example, movement in their dreams at night, leg shakings at night, waking up multiple times without any clear reason, for those polysomnograms are still the standard of care.
Dr. Luthra, do you think just having this simple device delivered to your home, where you can do it in the privacy of your home, has helped people get diagnosed quicker and better? I mean, to have to schedule a sleep away from home sleep study just seems it just seems almost impossible nowadays. So this must really help you get patients help.
Right, absolutely. I think a lot of primary care doctors, specialists such as cardiologists, use this device a lot because it is very easy to get patients to do it. Patients have less anxiety about doing this test, and you really can screen. So this is a good screening device. Let's say you find somebody to have a disease, then you can move them forward for treatments. And even if this test is negative, then it makes a step towards getting to the polysomnogram.
All right, tell us what sleep apnea is and how common it is.
So sleep sleep apnea is very common. We think the prevalence in the population is somewhere between 5 to 10% of the population, and it basically is a partial or a complete obstruction of flow of air into the lungs. So when we breathe at night and we sleep, there can be an obstruction to the airflow that is leading to a drop in the oxygen in your body, and that generates a lot of stress in the body. That stress then translates into poor rest, so you are waking up tired. That also doesn't let your heart rest at night, so you can end up with a lot of heart conditions like atrial fibrillation, heart failures, and it also generates a lot of hormonal changes in the body that lead to increased weight gain, increased blood sugars. So when I want to patients to think about apnea, it is not just snoring and a lifestyle condition. It is almost a chronic condition like diabetes or hypertension. You may not be symptomatic, but this condition, if you have, is impacting a lot of your organ systems.
Well, and think about what we just learned to live with.
Right.
We learned to live tired, and we just make do or nap or try to make up for it. But that was one of my questions: is how does it increase your chances of heart disease? Is that one of the biggies when it comes to bad sleep health?
Right. So there's a lot of research going on in this field. We know that from population studies, sleep apnea and cardiovascular disease are prevalent together. So there is definitely some association, and there's a lot of work going on how they associate. One of the things we think is because with sleep apnea, you do not get a drop in your blood pressure at night, and you do not let the heart rest. That can lead to heart problems. Also because sleep increases inflammatory markers in the body, and that inflammation also leads to cardiovascular disease. So there's definitely association between sleep apnea and high blood pressure, increased risk of heart attack, increased risk of strokes, and increased risk of irregular heart rhythms like atrial fibrillation.
I think all good health leads back to sleep.
Yes.
I would imagine you say that a lot.
Yes.
True or false? My spouse chronically snores, therefore he must have sleep apnea.
Not exactly true, but if they snore to the point that they are bothering your sleep, there may be some degree of sleep apnea. Snoring can be benign, snoring can be loud and still be benign, but a lot of times loud snoring could be one of the only symptoms that can trigger somebody to get evaluated for sleep apnea.
Okay, so that's one of the good signs you're going to look for to get somebody in. So coming up, we're going to talk about a popular device. You mentioned it, the CPAP, that a lot of people talk about. That's sitting right here. There's been a lot of advancements in it.
Right.
It's not as scary as it used to be. You said people get nervous because they feel like an octopus is put on their face at night. That's what you described, and I said that is what it probably feels like. So we're going to talk about that coming up here in just a bit. So guys, this isn't so bad. We're going to tell you, have some good options for you. But Alexis, I'm going to send it back in studio. I bet we've got a few questions.
I'll just start with Scott. Scott says that he read a recent study says that darkness, total darkness, is the only way to go if you want to get your best night's sleep. So Dr. Luthra, maybe you can ask him if that's true.
Yeah, what's the environment supposed to be like in there?
So yes, I think light is the strongest, what we call Zeitgeber, or the influencer on the internal clock or the internal sleep and wake rhythms. There was a recent study where they said even a little bit of light exposure at night can lead to sleep issues. So obviously we don't recommend that in elderly folks or who need a dim light to make sure they don't have a fall or anything. But the darker you can keep at night, the better your sleep quality is. And especially after 8 or 9 o'clock, if you dim the lights so that you let your brain get ready to get into sleep and follow a consistent sleep-wake routine, that is exactly recommended.
So should you wear one of those masks if you can't get your room super dark?
You can wear them. Again, like I said, if you have any issues walking, getting up at night, and if you're elderly or fall issues, then not. But otherwise, you should, yes.
All right. Alexis, another question?
Yes, another question for Dr. Luthra. Laura writes that she's struggling to get a good night's sleep with her newborn, which everyone who's ever had a newborn can relate to that. She says, they always say sleep when the baby sleeps, but that's not happening. So what else can she do to make sure she's staying healthy when she's really hanging by a thread?
Yeah, that's fine. I just know sometimes.
That's a good question. Healthy mom means healthy baby.
Yes, and we invariably see sleep issues in with newborns and new mothers. It is really challenging situation. But I think getting your baby slowly to a sleep routine where they take a longer period of sleep in one chunk and then 3 or 4 naps when they are that young, getting as soon as possible for for them into getting into that schedule helps, and also making sure the light and dark cycles are followed when they are born also helps, because when babies are born, they are coming from a completely dark environment. So with that dark environment, their internal clocks are really not synced to day and night rhythms yet. So making sure you expose them periodically to day and light, and getting them into a longer sleep schedule and then a few naps will help you get a better sleep.
Gosh, that is a tough one, because
Yes.
you're so desperate for
Yes.
sleep at that time,
Yes.
for sure. Alexis?
I have another question that just came in from one of our Facebook viewers. Yen Liang has a really interesting question. Yen Liang writes, would sleep deprivation lead to higher risks of getting ADHD or autism among little kids?
There is a lot of research in this field with behavioral sleep medicine and mental health in kids, and I was just reviewing some data on that. I think there is some relationships between poor sleep in kids and ADHD. A lot of times, because when you are fatigued and not rested, then you have a low concentration level, and sometimes that low concentration, low focus can be one of the symptoms how ADHD is diagnosed in kids. So even in adolescents, even in younger adults, when they come to me, we have diagnosed folks who were eventually found to have really chronic sleep disorders coexistent with ADHDs, and when we treat the sleep disorders, their behavioral disorders also start to get better.
Alexis?
Denise has a question about her Kindle. Denise wants to know if light from the Kindle is similar to the cell phone light when it comes to sleep disruption.
So it depends upon the Kindle. If you're using the Kindle with that ink tablet screen which has black letters and a gray background, not so much. But if you're using your colored iPad-like Kindle, yes, the light exposure from the screen can impact your sleep.
Makes sense.
Tony has a dilemma that he wants Dr. Luthra's help on. Tony writes, I'm concerned about my wife. I know she needs to see a doctor for a CPAP machine. I know she needs to see a doctor, but she's afraid to go to the doctor because she doesn't want to be put on a CPAP machine. So how would we help Tony out there?
Yeah. So
well, you've got
yes.
there's some good news for Tony and his
Yes.
wife. So
Yes.
tell us about what we got here, because you've got some new advancements in the CPAP machine.
Yes. So a lot of people hear from their friends what type of CPAP they're using, and a lot of that technology could be many years old. I wanted to show these masks so that people can realize, obviously this is not the CPAP machine, but the mask that goes on your face can be as small as this one, which is what we call a nasal pillow. You have silicone buds going into the nostrils and then wraps behind the ear, really soft material here, and really not very obtrusive to the face. This one is called a nasal cradle. So if you don't even like anything poking in the nose, then you can just have this sit under the nose, almost like this. Again, very least obtrusive max. And if there are folks who are breathing with their mouth open at night and cannot tolerate anything like this, the full face mask or a hybrid mask like this is also, you can see, not a very huge obtrusion on the face. And then I would also like to tell folks that, you know, it's good to just get started with evaluation, because you may end up having only mild sleep apnea. And if you have that, we can also do oral airway therapy, which means you can get a device which you place inside the mouth, advances your jaw and prevents sleep apnea without having to do any CPAP. So I would tell patients to come in, get evaluated, and then based on the degree of apnea, we can find something that works for them, even if it is not CPAP.
So is this as big as it gets? It's not going to get really any bigger than this? And what's the difference? It's only just the way you breathe at night would determine what type of mask you would use?
And your facial anatomy. So sometimes people have beard, sometimes they have a different type of face. So they will get comfortable with a different type of mask. There's a mask bigger than that, which also covers the nose entirely.
Okay.
I can do this, right?
Yeah.
You're good.
You
Okay.
can just put it like that. There are folks who wear a bigger mask and they love that.
Yeah.
They're like, we like the feel of it. It fits snug on the face.
Okay, so it goes over this way, right? I don't know if I
Correct.
can get this on.
Yes.
It goes this way and the mask goes down.
No, this
okay.
would be,
I
this
can't
would
even
be
figure out how
sitting
to get
under
it.
the nose, and this would be covering your mouth.
So my mouth goes in here?
Correct.
Okay.
Yes, just like that.
Okay.
Yeah.
Okay. So what do people say when they've never, I mean, how long does it take for someone to adjust to this?
So it varies. I have patients who are really scared about starting CPAP and they sleep one night and they feel like they had the best night ever. And in other folks, it can take 1 to 2 weeks.
Okay.
We do recommend some mask desensitization, so which means if you're really intolerant to a type of mask, first try to change the mask to something you can like. And after that, you can try wearing the mask in the evening for a couple hours without turning the machine on. And that leads to desensitization of our face to that type of mask. Similar to how we got used to wearing COVID masks. Initially, people would feel discomfort, wearing the mask all the time, but when you do it, you get used to it.
You get used to it. It's for the better good.
Yes.
You have to sleep on your back, though. Is that better? Is that the best way to sleep, is on your back?
Sleeping on the side. Sleeping on the back can actually lead to more snoring and more sleep apnea.
So you can do that with this comfortably.
You can do
Just
that.
gotta figure it out.
There are also masks where the hose comes out at the top, and these are even better for side sleep because the hose can rotate, and you can be on the side, you can be on the back.
Okay, I say it's not that bad, but I also don't wear one, so I'm sure it does take a lot to get used to. You study circadian disorder. What is that?
So circadian disorders are the disorders of the internal sleep and wake rhythms, and very common in younger adults and in the elderly folks. And they happen because of us trying to get light, when we shouldn't get light, trying to be sleeping when should be awake. So when we do that, we disrupt our internal sleep-wake rhythms, and that would lead to circadian disorders.
Are you familiar with brown noise? Are you familiar with that? I've heard of white noise.
Yeah.
Brown noise. It's something that's going on TikTok. I'm kind of out of the loop when it comes to that kind of stuff, but I thought maybe you would have heard of it. It's something that people are doing and then recording.
I do not have TikTok, but I know that any kind of noise depends upon what your preference is, can help with sleep if you can focus on that. But not particularly sure what brown noise
So
is.
it's saying it's the sound of cascading waterfalls and thunder and just nice
so
rainfall. That's nice.
Similar to white noise. I mean, I have an 11-month-old and he sleeps to rain sounds. And there are folks who sleep to waterfalls. Anything that can calm your mind and you get used to that sound at night helps with sleep. Varies with patients, but I think it's a similar concept. Some noise at night can help you sleep better.
Sleep better. All right. Well, let's help parents out. What's the best advice you have for parents getting their kids back on track, and maybe just some advice on how to improve their sleep health overall?
Yeah, I think the biggest thing is a consistent sleep and wake regimen. A good bedtime routine, lights cut down after 9 o'clock, where the lights are dim in the house. Cutting down the screen time. They can use screens if they need before 9, but after 9 making sure the screen time is low. Making sure the devices are turned on in that yellowish screen mode where they don't get a lot of blue light from the screens. And then after waking up, getting really bright light. So what we want to do is mimic how the sunrise and sunset happens. When the sunset happens, light should be dim. When you have a sunrise, you wake up, light's bright. When you try to do that, it takes a couple weeks after the schools open up, but the sleep syncs very well to that.
All right, this is an asking for a friend moment.
Yes.
Is melatonin okay for kids from time to time?
Melatonin is okay for kids. It is safe for kids, and it is used by a lot of pediatric sleep clinics. You are looking at a low dose. In school-going kids, you are looking at under 3 milligrams, 1 to 3 milligrams. In preschoolers, trying to keep it 1 milligram or less. But it is safer. It is safe in kids to be used. Yes.
All right. Before we get to any reporter or in more of our viewer questions, I did want to ask you, we do get a lot of questions about CPAP recall. This was about a year ago.
Yes.
What can you update us on that?
So CPAP recall has been a challenging issue, mainly because of the shortage of the recalled machines. The latest updates I got on that was Philips did a study where they took their devices that were recalled and actually looked in a lab for the organic compounds that are coming out for the particulate matter, and they said a lot of those were under the safe limits. Now I'll say that with caution because I don't know what standards exactly they use to detect that, but there may be more updates coming on that. So far they haven't changed the guidelines that these devices are still recalled, but I'll say that a patient should have a discussion with their sleep doctor based on the severity of the apnea. They may still benefit from using the device if their apnea is more harmful to their health than the device itself.
How did COVID affect patients that you see? How did that affect people? Just the anxiety, how did it affect people?
I think in terms of sleep, sleep definitely got worse in the period of COVID. Because of anxiety, because of behavioral changes, because of a news cycle that is always stressful, people got poor sleep. But on the other hand, people, when they showed up to COVID clinics, got detected with more sleep disorders. So I also see a lot of patients coming because they saw a pulmonologist or a doctor, told them about their sleep, told them about their shortness of breath and all, and got a sleep study done and got diagnosed. So they came to me and then got started on treatment. So I think sleep definitely got worse in COVID, but on the positive side was there were more testing done and people got diagnosed with apnea.
Great news. Hey, Alexis, I'm going to send it back to you to see if we have any more viewer questions or reporter questions.
Do you have any reporters on the line that have any questions for us? Looks like no reporters as of now. We do have a really good viewer question, this one again for Dr. Luthra. Ann writes, my husband snores, keeps me up all night. How do I get him to stop, and should I get him into a sleep study? She's probably speaking for a lot of wives.
Yeah, I think...
Yeah, right.
Yes, if your husband is snoring and loud to the point that he's waking you up, combine that with if he doesn't feel fully rested in the morning, a little bit tired, is easy to nap in the afternoon, I would say get a sleep test done, because it's better to get it done early so you do not let your heart, your brain suffer a very long period of time with low oxygen and airway obstructions.
What are the benefits of naps? You mentioned the nap.
So naps, are helpful if you keep it short. If you take less than 30 minutes of nap and it does make you refreshed, then they are a helpful thing to do. Typically not more than once a day. But if you are requiring multiple naps, long naps, or not even feeling rested after naps, that is a reason to get further into diagnosing what's going on with you.
Alexis?
I have a question, a COVID question. This one's for Dr. Hawkinson, and this is from Yen Liang. Yen Liang would like to know if prior infection of Omicron, like BA2, would generate stronger protection against BA4, BA5, or the other variants.
Yeah, actually there's been recent published studies on this in the New England Journal of Medicine, most recently in the last couple of weeks. I think a lot of it is from Qatar. And what it showed was that you still can get reinfected. Maybe the time from the Omicron infection to BA4, BA5 is less. There is an offering of protection there. You still have that offering of protection from previous infections as well. But again, that data is it is muddied because of different layers of vaccination and all of those types of things. So yes, there is some protection there. But it is not probably as strong, and reinfection can occur maybe a little bit sooner. But again, what is important is that we aren't necessarily seeing the severity, especially in those people that are up to date with vaccination.
Jean has an interesting question. Jean writes, with the virus constantly mutating, is the idea of herd immunity now an obsolete idea?
Yeah, I think we aren't going to be thinking about herd or population immunity in the same sense as we would for, say, chickenpox, when those people had chickenpox or got protected through vaccination. It is much different because we know that you still have that ability to get infected. You still can spread that virus, even if it may be for a little bit shorter time, especially if you're up to date with vaccination. But I think that traditional concept of population or herd immunity, as we've known it, is really not going to be applying here to SARS-CoV-2. Question
for Dr. Schmidt-Key. This is an interesting one. Not sure if you have the answer to this one off the bat, but Julie wants to know if you believe what happens in Georgia with monkeypox will also be an indicator of what happens here in the metro with monkeypox. Because for viewers just joining us, Dr. Schmidt-Key says what she sees in Georgia is often what we later see in Kansas City. Do you see that correlation with monkeypox, or is it too soon to tell?
I kind of think it's too soon to tell. Like I said earlier, I think that because viruses don't pay attention to borders, and we've kind of eliminated a lot of the protective measures for COVID that perhaps may have helped with this too. It's kind of hard to see where this is going. I think we should prepare for the possibility that we are going to have more cases of monkeypox in the local area. I don't think it would be outside of the reasonable spectrum for us to see that.
Shirley has a question for Dr. Hawkinson. Shirley wants to know, if you had a smallpox vaccine as a child, do you need another vaccine as an adult to not get monkeypox?
Yeah, that's a great question. So we know that smallpox vaccination in the United States stopped in 1972. I think there were some other clinics that continued to do it for about another year just because they didn't get the message. But in general, Smallpox vaccination stopped in 1972, which is unfortunate. I was born in 1974. I would have certainly loved to have gotten vaccinated. What we have seen is that you still do have protection, 80% or more protection if you did receive smallpox vaccine. Again, we don't know the full extent of that durable immunity from that smallpox vaccine, but having had that smallpox vaccine from 1972 or before that is going to offer you protection. In that first MMWR that was published by the CDC that looked at the first 16 or 17 cases of monkeypox in the United States, there was one patient that was, I think, around 60 or 65, so obviously they would have been vaccinated. But in general, if you have been vaccinated against smallpox, again, if you were in the United States and born in the United States before 1972, you would have been vaccinated. You are going to have a substantial amount of protection from that.
So for anyone else who was born after 72,
Yeah.
no protection unless you've gotten the vaccine?
Correct.
Because of the monkeypox?
Yeah.
And along those lines, Jean had a follow-up question about monkeypox, wanting to know, are we certain monkeypox is not airborne? How do we get monkeypox?
Yeah, so we, again, certainly you can get it on respiratory droplets. That is not as common as that close contact. So we are quite certain about that. Obviously, if you are having close contact with somebody, say kissing or being close, in close conversation with them, there is that chance, but the vast majority of people who are getting monkeypox are due to that very close physical contact, not respiratory transmission. Again, you can also get it from people's clothes or bedding if they have had open wounds and that virus or that drainage from those wounds gets onto that bedding or those clothes.
We have several more COVID questions coming in and monkeypox questions, but I want to toss it back to Jessica in the field with her sleep doctors and also Dr. Schmidtke as well. Jess, why don't you take it from here?
I want to ask you a little bit about what you want people to know about if they do not come in and get a test. What are some, you mentioned heart issues, but let's talk about a few things because we want to encourage people.
Right.
The CPAP machine isn't so bad. The home testing is really easy. What do you want them to know so that they're putting their health number one?
So, like I said, I think I want them to understand sleep apnea does impact your quality of life with snoring and feeling tired. Sometimes we learn to live with it. But beyond your quality of life, it impacts a number of very important organs in your body. For example, patients with moderate to severe apnea are at higher risk of developing atrial fibrillation that can lead to a stroke. It also can lead to uncontrolled high blood pressure, which we know has its own adverse effects. It can impact long-term cognition and memory. So patients having severe apnea for a very long time may also start to see changes in your memory and cognition. Weight gain is a big one. I always say there's a vicious cycle with sleep apnea. You gain weight and you develop apnea, and then apnea with hormonal changes can lead to more weight gain, more apnea, more weight gain. It's harder to lose weight because your body is acting against you, plus you don't have energy to work out. So you're basically going down a track where you're getting poor and poor health if you let it go longer without treatment.
Fair to say that the majority of sleep apnea patients are overweight in some capacity?
Most cases are, but you can also develop apnea without obesity, depending upon how narrow your airway is or how your facial anatomy is.
Alexis, I'll send it back to you for some more COVID questions.
We're getting, every time I look at my phone, Jess, it just keeps refreshing with more and more. Joellen wants to know, what are the chances, this is for Dr. Hawkinson, there will be an updated booster by the end of October?
Yeah, I think we are expecting that. I think recommendations should be coming out in August or early September at the latest, was the latest timeline that I had heard, and they are working to have those updated boosters out by October, November. So I think that's what we're expecting. Again, what we've expected from the most recent press releases a few weeks ago was that they would be a bivalent vaccine, meaning there are two different spikes in there, the original Wuhan isolate and then now an Omicron spike as well. I haven't heard if they are going to try to update from the first Omicron, which is now, again, defunct. We aren't seeing any circulation of that, or to a BA4, BA5. Still don't know the full information on that. But yes, it should be out hopefully by October, November time period.
I want to send this one to Dr. Schmidtke. This is a question from Sean. Dr. Schmidtke, Sean would like to know, what is the treatment for monkeypox? If you catch it, what happens to you? What do you go through?
This is really probably, I'm sorry, I'm going to defer to Dr. Hawkinson because he's the clinician on this.
Got it. Dr. Hawkinson?
Yeah, so in general, there is no treatment for monkeypox. It is supportive care. We do have two antivirals that we can use. The most recent CDC recommendations are that people that do have monkeypox here in the United States in those populations should get treated if they have an unusual presentation, which most of the cases right now for monkeypox do. So that would probably include most people. The ability to get that therapy is difficult. HHS or the administration has improved the paperwork and the ability to do that. But there is a treatment, but in general, most people will not need treatment. They will recover in 2 to 3 weeks.
What happens to you when you get it? You just get
you develop
pox all over?
Yeah, you develop sores, especially what they are seeing now, again, is more in the pelvic area, the genital region. In this certain outbreak, because of the nature of it and the close contact, you get sores. They will evolve to become from blisters to umbilicated areas to pustules, just as you said. They will eventually scab over, again, similar to chickenpox. And once that happens, you are no longer contagious. But they can be very painful, and it can cause people a lot of pain, certainly affect your quality of life for those 2 to 3 weeks for sure.
Question, a follow-up question from one of our viewers. Is the monkeypox vaccine just one vaccine, or is there a second shot or a booster?
Yeah, so as far as I know, there are 2 vaccines available, and again, they're smallpox vaccines. So ACAM 2000, which is the traditional smallpox vaccine, where they actually scrape into your arm. When you see people who were born in 1972 or before, you see that little mark on their deltoid or their shoulder here. Because they're scraping, actually putting that virus into the skin to cause that immune reaction. The other one, the Jynneos, I believe, is a 2 vaccine dose, and that is more of the traditional injection vaccine that we know about for COVID or for influenza. That is how that is administered. I don't believe there are any recommendations for updates or boosters to those initial series of vaccination.
Okay, I'm going to keep refreshing this page. I think I got most of them right now. I'm going through them in order, but I'll jump in when we get more questions, and we might get them just throughout the day. You might be busy on
I'll
Facebook.
Be around.
I mean,
I'll
busier.
Yes, that's fine.
Busier. Jess? All right, we're going to wrap this up. This has been such a fascinating broadcast. Thank you so much for joining us. I want to get to final thoughts. Dr. Schmidtke, do you have some final thoughts for us?
Despite what you may have heard, COVID is not over. We, of course, want you to be fully up to date on your vaccines and maybe take some more precautions than you have in the recent past. So avoid crowds, wear your mask if those crowds can't be avoided, that sort of thing. But, you can care about your community in small ways and in big ways, and we all have things that we can do to help with that problem.
I want to see, is Dr. Luthra still with us? I know he had to treat patients. Okay, because we had another question from Ruth, but Ruth will hopefully get that answer for you online later. Dr. Hawkinson, what are your final thoughts?
Yeah, I think I want to continue to reinforce that message that Dr. Schmidtke gave. Understand the virus is circulating in a quite high amount right now. It has been. We have seen hospitalizations slowly tick up over the past few weeks, and I think that is just a consequence of the continued spread of the virus. So understand your individual risk. We have good data now to support the fact that if you are up to date with your vaccine and booster, you are going to be protected from those most severe outcomes and hospitalization. So it's vitally important to do that. Also understand those situations that you're going into. If you have a concern about your health and your risks, then you may not want to go into that certain situation. You can always mask. Wearing masks is okay to do. It does even protect the wearer, even if other people around you are not masked as well. So I think those are the big issues there. And hopefully we can start to see a downtrend in hospitalizations. We know that will come a little bit later, but hopefully it will start to turn around and have less hospitalizations. And certainly we know that your chance of death is anywhere from 3 to 6 times higher if you are not up to date with your vaccine as well. So would also like to thank our guests with the sleep medicine, and I would encourage everybody just as my parents do, they have a nice matching set of CPAP, so they have to carry that around with
That's
them
love.
to all the hotels. Yes, so it's good for them, and hopefully they can get some good rest.
Hey, there's a reason why they're still together.
Absolutely.
Nobody's keeping everybody up all night by
right.
snoring.
That's right.
Thanks, Dr. Hawkinson, and thank you, Dr. Schmidtke.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.